Patients often come to us with cervical degenerative issues, disc herniations, et cetera, that can cause neck pain, arm pain, and spinal cord dysfunction. And as we do an evaluation, we have a couple of mainstay surgical options. One is to do an anterior cervical fusion, and the other is to do an anterior cervical disc replacement. The final surgical option is to do posterior cervical surgery. I want to talk a little bit about the differences between anterior cervical discectomy and fusion and cervical disc replacement. Anterior cervical discectomy and fusion and cervical disc replacement are very similar surgeries. They're done for similar reasons. The case is almost exactly the same until you get to the instrumentation portion of the surgery. So with anterior cervical discectomy and fusion and cervical disc replacement, we make an incision in the front of the neck, we go down to the spine, we remove the entire disc, we remove all the bone spurs, and we remove the posterior longitudinal ligament. And we reach a point in the surgery when the spinal cord and the nerve roots at the level of the surgery are completely decompressed. The next step is the different step. With an anterior cervical discectomy and fusion, we place a spacer in the disc space and a plate and screws, and we add the patient's own bone back in for fusion. With a disc replacement, we place an artificial disc into the disc space. We then close the wound. In my experience, the recovery is very similar between the two. The patients have a 4 to 6 week recovery for a 1 and 2 level disc replacement and a 1 and 2 level fusion. They're fairly similar. The restrictions, they're the same. We recommend really to all of the patients being mindful of your movement and incrementally increasing your activity as tolerated. The long-term outcomes are different though. The artificial discs have better long-term outcomes than the fusions across multiple studies. So we choose to do an artificial disc when we think we can. If there's kyphosis, or in other words, an abnormal alignment of the spine or some sort of deformity of the spine, usually an artificial disc is not going to be sufficient. If there's severe arthritis, especially when it's arising from the facet joints, an artificial disc may not be sufficient. If we're talking about multiple levels, more than 2 levels, artificial disc is not technically FDA approved for that, and we have a hard time getting insurance to approve it. There may be options to pay cash, in some centers around the country accept cash for 3 and 4 level artificial discs, which is theoretically an option, but insurance is harder to get covered for that. If you visit with a surgeon that says that artificial discs don't work, I think they're probably not reading the current literature. There is more evidence for artificial disc replacement in the cervical spine than just about anything in spine surgery. There are many, many randomized controlled trials that have proven benefit, short and long term, for cervical artificial disc replacement. In my practice, if we can do an artificial disc replacement and accomplish the goal of getting the nerve roots free and the spinal cord free and alleviating the pressure on the nerve and the pain down the arm, etc., we will choose to do a disc replacement. If we cannot accomplish those goals with a disc replacement, then the anterior cervical discectomy and fusion would be our secondary choice. If we can't accomplish the goals with an anterior surgery, then we would do a posterior surgery, which I think has a harder recovery and maybe the outcomes aren't quite as good. And that's how I really address the cervical pathology from a surgical perspective. Artificial disc is a great option for patients, and the outcomes for both artificial disc and cervical fusion are excellent, but the artificial disc patients do better overall.